So I will start the first presentation with a clinical case that shows how we can get advantage of the new eco techniques that have been developed in the last year, not only to improve our laboratory productivity, but also make a difficult diagnosis and also staging the disease in a way that has been unprecedented with the conventional eco techniques. The case is relatively simple. It's a 67-year-old woman. The ACG was normal with sinus rhythm, normal QRS. The patient is quite obese. She's quite short, 1.54 meters, but it's definitely obese with a body mass index of more than 35 kilograms per meter square. She also has some metabolic syndrome. She's hypertensive with type 2 diabetes and also has a mild BPCO. The patient comes to the echo lab because of a worsening exertional dyspnea for 3 months, and the echocardiography study has been requested to assess the left ventricular function and to estimate the pulmonary pressure in this lady. We started with the assessment of the left ventricular systolic function, and this can be done nowadays very easily and very quickly using the heart model. And 3D echocardiography, you can acquire a data set of the left ventricle and the left atrium in very quickly, because you don't need any more multi-beat acquisition during breath hold, but you can just acquire in a single beat acquisition, and this is usually done in less than 1 minute. And when you have the data set, you can immediately start with the quantification that also in this case is fully automated. What we have to do is just to set the sensitivity of the border setting, but this should be done just once when you set up your echo machine, and then you leave it for all the patients. And we use the recommended setting of 60 for the end diastolic contour and 30 for the end systolic contour. Then you just press a button, and in a few seconds, actually less than 1 minute, the machine is able to make the contour of the endocardial and the epicardial border of the left ventricle, as well as the endocardial border of the left atrium. And here you have the fully quantitation of the cardiac chambers with the volumes of the left ventricle, the ejection fraction, the length of the ventricle, the stroke volume, the cardiac output, the left ventricular mass, and also the maximal and minimal volume of the left atrium with the total left atrial emptying fraction. So you have a lot of data that can be acquired very quickly using your new technology, that is the heart model. And then, having seen that the ejection fraction was 51, so at the lower limits of normality, actually mildly reduced in a lady that should have at least 54% of ejection fraction according to current guidelines, we moved to analyze the left ventricular diastolic function, collecting all the data that should be collected according to the algorithm for the assessment of the diastolic function that has been issued by according to the recommendations of the American Society of Echo and the European Association of Cardiovascular Imaging. So we assessed the E/A ratio. We assessed the size of the left atrial volume that is severely dilated, 64 milliliter square. We also calculated the average E over E prime that was in the middle range, but that there was no enough tricuspid regurgitation to measure the tricuspid regurgitation velocity and to estimate the pulmonary, the systolic pulmonary pressure. So putting all of these data in this relatively complex algorithm to assess the left ventricular diastolic function, we see that according to the E over A, the patient is in the mid of the algorithm. Then we have an E over E prime of 12, but we have an LA volume that is severely dilated. So the E over E prime doesn't qualify the patients. The LA volume qualify the patients for the presence of diastolic dysfunction. These two are contradictory, and unfortunately we couldn't have the velocity of the tricuspid regurgitation. And so we are in a quite in an uncomfortable position, because in this patient we are unable to determine the left atrial function, pressure, and the diastolic function. And this is not so rare, because with the current algorithm, there is a variable incidence of 15–20% of the patients that just are in the indeterminate portion of the algorithm. And so we moved to another tool that is available on our Eco platforms. That is the possibility to have a fully automated quantitation of the left atrial strain. So when you have acquired your dedicated, non-foreshortened, 4-chamber view focused on the atria, you can just press a button, and immediately you will have a fully automatic delineation of the endocardium and the quantitation of the parameters of the left atrial function. So we have selected the 4-chamber view, and here we have the possibility to choose having as a reference the R wave of the ECG, or having at the reference the P wave on the ECG, as recommended by the standardization document issued jointly by the European Association of Cardiovascular Imaging and the American Society of Ecocardiography. We used just the 4-chamber view and the R wave as a reference, and then the software provides immediately in less than 30 seconds. This is very quick and very reliable, I have to say. The reservoir phase of the function, the conduit phase of the function, and the contraction or booster pump function of the left atrium. And as you see, all of them are severely reduced in Our Lady. And this is a very important clue, because has been shown by Singh and co-worker from the Ecolab in Chicago, that the measurements of the left atrial strain, and particularly of the reservoir function of the left atrial strain, is a very efficient way to assess the left ventricular diastolic function. And particularly, they showed that when the left atrial strain during the reservoir is less as 20% or less, you have a very high sensitivity. You see here a very high accuracy, I would say. You see here the area under the curve that is 0.76 to diagnose a left ventricular diastolic function. And in this paper, it's really interesting because they compare the sensitivity of the single measurement of the left atrial strain compared to the complex algorithm of diastolic function that we have seen before. And you see that both in all subjects, you have a better accuracy of the LA strain compared to the complex algorithm. And this is particularly true because the specificity is definitely higher for the left atrial strain. But the very important thing is that this is not it's valid both for patients with the low ejection fraction, but even more important in patients with the normal ejection fraction, and also in those patients, the single measurements of the left atrial strain during the reservoir phase of the function of the left atrium outperform the algorithm in the guidelines. Then we moved to another important part of the assessment of the cardiac function of this lady, and it is the assessment of the right ventricular function. And once again, we can get advantage of the heart model. Also for the right ventricle now, it's available a single beat acquisition where you can acquire the entire right ventricle using the right ventricular focused apical four-chamber view. Similar to what we have said for the left ventricle, is a single beat acquisition very, very quickly, and also the analysis is performed in a fully automated way. I have to say that for the right ventricle, the fully automated algorithm, usually any algorithm for the right ventricle doesn't work very well in a fully automated mode because of the highly trabeculation that are present in the right ventricle. And in our experience, and also from the other groups, manual editing is needed in almost all of those patients. But even these, having already traced the control in diastole and systole with this very user-friendly software package, the acquisition and the analysis time are usually completed in less than 3 minutes. And also I have to underline that all those functions, the quantitation of the left ventricle, the left atrium, the left atrial strain, and the volume and the ejection fraction of the right ventricle are on card on your machine, and so it can be quickly done during the echo examination in order to provide immediately a feedback to the operator. It's important to look at the function of the right ventricle. It's now we know definitely that the answer is yes. This is one paper published last year by Elena Surkova from our lab. It's more than 400 patients, consecutive patients that have been studied in the Eco Lab for clinical indication in various cardiovascular disease. Those patients were then followed almost 4 years, during which 59 deaths occurred. And as you can see here, having a normal ejection fraction that is more than 45% is a very strong predictor of your outcome in terms of survival, because you can compare how good is it to have a normal ejection fraction compared to have a reduced ejection fraction. And when we compare the prognostic value of the right ventricular ejection fraction, that is the green line, compared to the more conventional echo indexes like the TAPSE, that is the blue line, and the fractional area change of the right ventricular area, that is the red line, you see that the predictive accuracy of the right ventricular ejection fraction is significantly higher than those of the conventional indexes of right ventricular function. Also, looking at the relative importance of the function of the left ventricle and the right ventricle, this is again Elena Surkova that made an interesting observation. She were interested to see if it is really so important also to assess the right ventricle. So she divided the patients in 4 groups. The first one where both the left and the right ventricular function were normal. A second group where the left ventricular function was reduced, but the right ventricular function was preserved. A third group where the left ventricular function was preserved, but a reduced right ventricular function. And finally, the last group where both ventricles were dysfunctioning. And as you can see here, both in terms of all-cause mortality and also of cardiac death, having a reduced right ventricular function with the normal left ventricular function is much worse in terms of prognosis than having a reduced left ventricular function with the preserved right ventricular function. Of course, when both the ventricles are dysfunctioning, this is the worst scenario, but here clearly shows this paper how important is the assessment of the right ventricle in our patients with the preserved left ventricular ejection fraction in determining their prognosis. And finally, we are now able not only to say that the right ventricular function is normal or abnormal, but here is an important paper by Denisa Muraro and co-workers, again from our lab, that was published in the European Journal of Cardiovascular Imaging at the beginning of this year. And this is a cooperative study between us and the group in Japan at Kitakyushu, Professor Masaki Takeuchi. We developed in Padua the threshold values for defining normal ejection fraction, that is over higher than 45%, mildly reduced ejection fraction between 40 and 45, moderately reduced between 30 and 40, and then severely reduced ejection fraction below 30%. And then we asked our friends in Japan with a similar population in terms of size and also in terms of follow-up to check if these cutoff values work in terms of prediction. And you see here that both looking at cardiac death or looking at the occurrence of major adverse cardiac events, that is the composite endpoint of cardiac death, non-fatal myocardial infarction, ventricular fibrillation, and rehospitalization for heart failure, this threshold of left ventricular function nicely separate a group of patients with increasing risk of bad outcome. We have not finished because we have seen that in our patient, the right ventricular function ejection fraction was normal, but this is the ejection fraction is just the pump function. It doesn't tell us that much about the function of the myocardium. So we acquired two-dimensional images of focused on the right ventricle and asked the software package to assess the strain of the right ventricle. This is again a fully automated package that is on board on your echo machine that in less than 30 seconds make an automatic tracing of the border of the right ventricular endocardium and gives you a quantitation of both the free wall longitudinal strain and the 4-chamber global longitudinal strain. And in this case, you see that the strain of the right ventricle is definitely reduced. And again, this is important from the prognostic point of view because a paper by Mara Gavazzoni, again from our lab, that looked at the prognostic value of a free wall right ventricular strain in a more than 450 consecutive patients undergoing echo for clinical indication. And you see that having a normal or an abnormal strain of the free wall with the cutoff value set at 22% is very important in determining your prognosis. Here is a combined endpoint of cardiac death and rehospitalization for heart failure. And even more interesting is the fact that also if you take the patients with the normal TAPSI, so TAPSI more than 20 millimeters, still in those patients, the presence of a reduced strain has a strong prognostic indication. So it seems to have an added value compared to conventional TAPSI. So how these to put it together and to verify that our diagnosis was correct, that these patients has indeed an estimate of heart failure with preserved ejection fraction, we performed an exercise right heart catheterization. And the exercise right heart catheterization was really interesting because at the rest, the pulmonary pressure as well as the capillary pressure were normal. But just raising the leg of the patients created an abrupt increase of the mean pulmonary pressure as well as of the capillary wedge pressure. That further increased during mild exercise in these patients, creating a pulmonary hypertension and a huge increase of the mean capillary pressure. After just 1 minute of recovery, almost normalization of everything. So this explains very well the hemodynamics, the mechanism of the dyspnea on effort on those patients, and also justifies the findings that we had at our echo study. Indeed, the measurements of the strain of the different cardiac chambers, the left ventricle, the left atrium, the right ventricle, allows at rest and during exercise, allows a staging of the compromission in those patients with heart failure and preserved ejection fraction. And this has nicely been shown in this review paper that appeared in JACC Cardiovascular Imaging on early January this year. So just to conclude, I wanted to share with you some concepts. The first one is that the last generation echocardiography machine allow a comprehensive assessment of the cardiac performance, that not only the left ventricular ejection fraction, but the pump function and the mechanics of all 4 cardiac chambers, left ventricle, left atrium, right ventricle, and eventually right atrium. The use of the artificial intelligence provides a fast and reproducible quantitation tools, improves the workflow of the analysis of echocardiography data sets, making advanced quantitation feasible also in busy clinical echo labs too. And the fully automated quantitation tools that we have on board on our echo machine as well as on the workstation increase the reproducibility and repeatability of advanced quantitation analysis like 3-dimensional echocardiography and strain and echocardiography. And last but not the least, that the possibility to make a comprehensive quantitative assessment of cardiac function allows a complex diagnosis and risk stratification at bedside using safe, cheap, and widely available imaging modality. If you are interested in a three-dimensional echocardiography, I wanted to refer you to this textbook of three-dimensional echocardiography that we edited together with Professor Roberto Lang, that will be with you tomorrow, and Denisa Muraro from my lab. Or if you prefer to have a direct teaching, you can join us when this coronavirus infection will be ended, and hopefully it will be next autumn. In November, we will run again our intensive course on 3D echocardiography here in Milan. And having said that, I want just to thank you for your kind attention